Good afternoon to all, and today we are going to talk about central venous catheterization. And before I talk about central venous catheterization, I would like to introduce you. You are from batch 32 and you are doing shadow housemanship, and today is the best opportunity that we record this procedure and upload it for others so that the others are benefited. Would you please introduce yourself? Now let me tell you here that whenever we have to do central venous catheterization, we use the internal jugular vein usually. And what is the reason why we use internal jugular vein as central venous catheterization? The reasons are that this vein has got good external landmark, and there is an improved success when we do this catheterization under ultrasonography, and there is least risk of pneumothorax than subclavian catheterization. And one more thing is that the bleeding here can easily be seen, recognized and controlled, and the malposition of catheter is very rare in this vein, because this vein has a straight course to superior vena cava on the right side. This vein is superficial and easily accessible, and also that carotid artery is also easily identified in this area. So these are the reasons we choose the internal jugular vein for central venous catheterization. Now let us talk about indications of central venous catheterization or indications of jugular venous catheterization. The indications are central venous pressure monitoring, hemodialysis, plasmapheresis, and insertion of pulmonary artery catheter. The other indications are whenever a person is in cardiac shock, or whenever a person has got severe hypotension. At that time there will be inability to obtain the peripheral vein access. So peripheral veins in these conditions will be collapsed. It will be very difficult to access the peripheral veins, so we resort to central venous catheterization in such cases. Also the indications are when we have to give large amount of concentrated fluids, when we have to give massive blood transfusion to the patient, that too when we have to give it rapidly and in short period of time. The other indications are, as I said, cardiac catheterization, pulmonary angiography, and whenever we have to give total parenteral nutrition. When I say total parenteral nutrition, I mean to say that we can give through this route amino acids, carbohydrates, fats, because these are now available as IV drips available in the hospital or in the market, and these can be given through this route. And we can give up to 400 ml of fluid per minute through this route. The another important indication of central venous catheterization is when we have to do transvenous pacing, when we have to insert transvenous pacemakers to pace the heart, then this is the route we have to choose. Now let me talk about the contraindications of central venous catheterization. The contraindications are absolute contraindications and relative contraindications. The absolute contraindications are superior vena-cava syndrome and infection at the site of insertion like cellulitis, burns, severe dermatitis and so on. And the relative contraindications are coagulopathies, bleeding disorders, and if the patient is on anticoagulation or thrombolytic therapy, if newly inserted pacemaker wires have been put in the patient. The other relative contraindications are distorted local anatomy, vasculitis, when patient is unable to cooperate, or if there is a presence of carotid artery disease. The other relative contraindications are thyromegaly, if the patient has to undergo neck surgery, if patient is not tolerating Trendelenburg position, or if patient has pneumothorax on the opposite side, and last but not the least, if patient has high end expiratory pressure on mechanical ventilation. So these are the contraindications of central venous catheterization. Let me talk about the complications of central venous catheterization. The complications are arterial puncture with hematoma, arteriovenous fistula, hemothorax, chylothorax and pneumothorax, because you may injure the lung causing the pneumothorax, and the other complication can be that you may injure the nerves that come out of cervical spine that form the brachial plexus. Any of these nerves can get affected, and you may also injure the satellite ganglia resulting in Horner syndrome. The other complications are air embolism or catheter or wire shearing. Then there can be complications due to the presence of this catheter in the internal jugular vein. The complications can be thrombosis, thromboembolism, infection, sepsis, and the other complications can be endocarditis, arrhythmias and hydrothorax. So these are the complications of central venous catheterization. So I have told you what are the indications, complications and contraindications of central venous catheterization. And once you have got this background knowledge with you, then you will go to the patient and may I ask you what are the steps you will take to perform the central venous catheterization? Which is the first step? The first step is that you go to the patient, and if you find patient is conscious and alert, you take the permission from the patient that you want to do central venous catheterization on him. Also, you will explain the benefits as well as adverse effect of central venous catheterization to the patient. And if the patient agrees and gives you the consent, then you will maintain the privacy of the patient. You will take the patient to a sickles room, in a room which has got good privacy. What will you do next? The next step is that you will put the patient in Trendelenburg position. The patient's head should be tilted downwards around 15 to 30 degrees. because we know that whenever patient has got the peripheral veins collapsed, right, and there is no easy access to these veins, then you want to keep the patient in Trendelenburg position so that the internal jugular vein gets congested and dilated. We know the diameter of internal jugular vein is around 2.5 centimeters. It is a large vein, but in cases of severe hypotension, shock, the vein may be collapsed. So it is better that we put the patient in Trendelenburg position at a degree of 15 to 30 degrees. And once the patient is put in this position, then the internal jugular vein will become distended, and it will be easy for you to localize this vein and to insert the needle in the internal jugular vein. Now we got a specimen here. It is not actually, the head is not tilted downwards, so you have to change the position of this mannequin, and you have to keep this patient in Trendelenburg position, as I said, which is between 15 degrees to 30 degrees. Now this is the proper position, and once we have done this, what will be the next step? What is the next step you are going to take? The next step is you wash your hands, and after cleaning and washing your hands, you will wear the gloves. What will you do next? You will take the sterile gown, and you will wear the sterile gown. Let me help you. So you have to put on sterile gown, yes, that's right, and you will also put on the face mask and cap to cover the hair, because sometimes the hair can touch the patient's fluids and you may get infection. So wearing the face mask, wears the cap to cover the hair, face mask, sterile gown, and the gloves is on, so she is ready for performing the central venous catheterization. And she will try to expose the neck and try to locate the area where she has to insert the needle. But before locating this, she has to see whether all equipment is in order, whether all equipment is functioning properly. She has to check the central venous catheterization kit. So she will check the central venous catheterization kit. This is central kit. You can see it here. So this is the central venous catheterization kit, and different manufacturing companies make it slightly different. And let me show you the items that it contains. The first item in this kit is the smallest needle, or the thinnest needle, which has got 35 gauge and which is around 1 inch in length. This is thinnest needle. And why this is the thinnest needle? Because through this needle we will give local anesthesia, and so that the patient doesn't get too much of pain, it gets as less pain as possible. That is why this needle has to be thinnest needle, and it is attached with 3 ml of syringe, and 1% of lidocaine is given through this needle. Maybe around 3 ml. Now let me show you the another needle. This needle is, the another needle is 22 gauge needle. It is slightly thicker than the first needle, and its length is around 1.5 inch, and the gauge is 22 gauge needle, and this needle is called a finder needle, and this needle is attached with the 5 ml syringe. And this finder needle we use because we had to first fill jugular vein. Most books and most videos do not talk about. I am laying stress on this step because this is a very important step, that after the local anesthesia you just find out the internal jugular vein through needle finder. Why? Because this is not a big bore needle, so the puncture in the big bore needle, so the puncture in the vein will be very less, and there will be less chances of damage and bleeding or hematoma. So always use the needle finder before you introduce the needle introducer. And when I say needle finder, that the another needle is called as the needle introducer, and this needle introducer is about 2.5 inch in length, and it is 18 gauge needle. So it is a big bore needle, and which is to be introduced after the needle finder, which is to be introduced in the internal jugular vein to withdraw the blood, and then through this we can enter the catheter. And this introducer needle we can advance alongside the needle finder, or we can put this needle parallel to the needle finder, so that we can easily advance it into the internal jugular vein. So please don't forget that after the local anesthesia we have to use the needle finder. We have to use the needle finder to find out the internal jugular vein, and after the needle finder we have to introduce the introducer needle, which is a big bore needle around 2.5 inches in length, and this also is attached to 5 ml syringe. So we got different syringes in the kit. One is 3 ml syringe, then 2 syringes of 5 ml. Now let me show you. This is the xylocaine which we have to give 1% containing 1% lidocaine. And now let me show you the another item in the kit which is called dilator, and this is used for dilating the subcutaneous tissue. It should not be advanced too far. It should be advanced only 1 centimeter or 1.5 centimeter, because the internal jugular vein is so superficial. This is the 2 lumen catheter. This is also called as Sildinger catheter, and the technique is called as Sildinger technique or cylinder technique or Sildinger technique, whatever how you want to pronounce it. So this technique is used to advance the central venous catheter. And this has got the caps, and you have to cap the right. And now let me also show you some other items that are in the kit, and the other items are so all this is to be checked, that you can't perform the central venous catheterization unless you check the kit properly and you see that all the tools are present there for performing the catheterization. Okay, so I was telling you that the different companies, the manufacturing companies, they can have slight modification in the equipments. Some accessories may be there, some may not there, some may be less costly, some may be more costly. Like we don't have a manometer to measure the central venous pressure, and we also don't have a sheath catheter or sheath introducer. The sheath introducer is meant for when we have to do the pulmonary artery catheterization, when we have to introduce pulmonary artery catheter through the jugular vein. That time we don't need this catheter. We need a sheath introducer. The sheath introducer has got a side infusion port, right? And you see, that is also a catheter. But what is happening, that you will see in this procedure, we will be first putting the guide wire, and after the guide wire we will be using the dilator, isn't it? And after the dilator we will be using catheter. But in sheath introducer, what we do is that we put the dilator into the catheter. We put the dilator here. You understand my point? Then both the dilator as well as the catheter, both then are passed over the guide wire. You got my point? Yes. And then we remove the guide wire as well as the dilator and leave the sheath there. In case of pulmonary artery catheterization. So what I am saying, that in pulmonary artery catheterization we don't use this catheter. We use a separate catheter which is called as sheath introducer. The sheath introducer is like this, and it has got a side port through which you can do infusion, or you can draw the fluid, you can draw the blood and all that. So it will be like this when we introduce it. In the sheath catheter we put the dilator. You understand my point? So along with the dilator and along with the sheath we pass it over the guide wire. Then we remove the guide wire and the dilator and keep the sheath introducer into the jugular vein. That is how we do in case of pulmonary artery catheterization, or pulmonary artery, the catheter, when we have to insert the pulmonary artery catheter. Now you can pause it again, pause it. Now the another item in the catheterization kit is this guide wire, right? This is a guide wire.
Now what is this guide wire? This guide wire is J-shaped. This is called J-shaped guide wire. Why is it J-shaped? Because it has got a J-shaped bend or it has got a J-shaped kink here at the tip of the catheter. Why it has to be J-shaped? Because when it glides over the vessel like this, you understand my point? It won't penetrate the vessel. It will slide or glide over the vessel wall. So there will be less chances of perforation of the vessel. That is why it has to be J-shaped. So when tomorrow your doctors, don't try to cut it and make it straight. You understand my point? Because you already know. But this J-shaped guide wire, you see, this kink cannot pass through the needle. Can it pass? It can't pass. So it has to be straightened. How it will be straightened? So this guide wire has got another part here. This is called the sleeve, straightener, or this is called the straightener sleeve, this part. So if you hold back this guide wire like this band, so it becomes straight. You see, it becomes straight. If I make it forward, it becomes this thing. So when you are trying to introduce this into the needle, so you first straighten it. So this part is a straightener. Guide wire, this part is a straightener, which is called as straightener sleeve. You understand my point? Now this guide wire also has got some markings. You see, if you see, their markings are there in the guide wire. You got my point? The first marking should be around 10 centimeters. The first marking, right? This may be you can check. Anybody has scale? Just yes. See, you can measure it. See how much is the scale. First, this one. How many centimeters?
10 centimeters.
So this is 10 centimeters. The second?
Another 10.
So another 10. So you can also see, because you know that you have to introduce the catheter only 15 centimeters. But I will tell you later, it is not exactly the 15 centimeters. It has to be less. You understand that? I will give the reasons for that. The first of all, you see that there are markings. One is 10 centimeters. We have just measured it. The another is 10 centimeters. That means if you have to do up to the 15 centimeters, then you have to go up to here, isn't it? Because if you introduce too far this catheter, it may go into the right atrium and it may damage the heart. You got my point? So it has to be exactly around 15-16 centimeters. So this was about the guide wire, and then we got this 2-lumen catheter. As I said, that this is called a Sildinger catheter, or technique is called the Sildinger technique. Now this has got the ends are capped with the knobs. So we got a knobs also here. You can take the knobs here. Just take the knobs here. Yes. So you have to cap it. You understand my point? So cap it like this. See, the another knob is there. Okay. So these two ends has to be knobbed. So this was all about the catheterization kit. You got my point? Yes. Now, what is the next step?
Prepping the skin.
The next step is to check whether they are patent or not. So what you do is you take the syringe like this. You understand my point? And you take normal saline. You take 10 ml of normal saline and see whether everything is patent or not. So if I take first catheter, I put the normal saline and see whether it comes through other end. You understand my point? So it is coming other end. It means it is patent, isn't it? Because if you don't check and if it is not patent, then in the middle of procedure, what you will do? You will start shouting, crying, isn't it? So it is patent on both the sides. Then we will see whether this thing, the needles are patent or not. Whether the needles are, so this is one needle, so I check it here, so I see, okay, this is patent, isn't it? So I keep the needle here This is a sterile cloth here, isn't it? Then I take another needle, so I check it. So this is also patent. So it means I am checking the guide wire, I am checking the catheter, I am checking the syringes, I am checking the needles, everything is patent, everything, so I am satisfied. Then we got other parts, the equipment is like we got a draper here. So this is a draper by which we can drape the area. Then this is the gauze, and we can clean it by the gauze, right? And then we got a suturing material here. We have to anchor the catheter. You got my point? And this is the needle here, suturing needle. Then we got a adhesive plaster or the wrap by which we can wrap the jugular venous catheter, or the adhesive or plaster, we can fix it over the catheter. So everything is here. You got my point? So, and we got also the probe, the ultrasound probe, that if we have to do ultrasound guided catheterization, then we can do ultrasound guided catheterization. You got my point? Now I forgot to tell you why we choose this vein. When I was talking to you first, that why we choose this vein. One important factor is that the success rate of catheterization has improved. Success rate of catheterization has improved after the ultrasonography. So if you do the central venous catheterization under the guidance of sonography, then success rate is very, very high. It is rare that you will fail. You got my point? So this was all. Now we move to the steps. So you can show us now the steps. How are you going to perform the jugular venous catheterization?
Okay, after you're going.
So this kit also contains the chlorhexidine applicator. The applicator by which you can just clean the area. You understand, Payman? We call it as chlorhexidine applicator. So here we will be using the sponge holder, and we'll be using the gauze. You got my point? The gauze will be soaked in the chlorhexidine, or it will be soaked in the betadine, and then we'll be cleaning the area. You got my point?
Yes.
Did you understand my point?
Yes.
Okay, so I think we are talking about each and every item of this kit. Now please show us the steps.
After positioning the patient in the Trendelenburg position,
Yeah.
find the 2 pits of the sternocleidomastoid and mark.
Okay, I want to just interrupt you here because I know you know this procedure. This is called central procedure. There are 3 procedures. There are 3 procedures. There is 3 approaches. How to approach the jugular vein. The jugular vein can be approached by three approaches. One approach is called anterior approach. The another approach is called central approach. The third approach is called posterior approach. So how many approaches are there for catheterization? 3 approaches. Now, first I will show the anterior and posterior approach. Then you show the central approach. What you were talking was the central approach. Now, what is the anterior approach? The anterior approach is that when you have turned the head on the left side, right? So this becomes exposed, this part. So you find the thyroid cartilage. Thyroid cartilage is this cartilage, what is called as Adam's apple. So you find the Adam's apple. So this is Adam's apple here. You got my point? So lateral to the Adam's apple or lateral to the thyroid cartilage, you go like this. And along the medial border of sternomastoid muscle. This is a sternomastoid muscle. This is one end of sternomastoid muscle. This is another end of sternomastoid muscle. This is sternal end. This is clavicular end. So the anterior approach is that you take a line from the thyroid cartilage and go laterally, right, along the medial border of sternomastoid muscle. You got my point? You have to inject here the needle here, and this needle has to be at 45 degrees and it has to be ipsilateral to nipple. towards the ipsilateral nipple. You got my point? This approach is called as anterior approach. Another approach we got is the posterior approach. The posterior approach is that you divide this is the clavicular head of this thing, and this is the sternal head. So this is the sternal head, isn't it? So what you do is that you take this head, the sternal head. You understand my point? And you divide from clavicle to mastoid process. So this is a mastoid process here. So you divide this and this into 3 parts. And insert the needle at the first 1/3 of this area. So 1/3 of claviculo-mastoid area. From clavicle to mastoid, the first 1/3 is here. This is the first 1/3. So at this area you insert the needle. But this insertion of needle will be towards the sternal notch. It will be towards the, it is direction will be sternal notch. It will be also 30 to 45 degrees. This will be also 45 degrees. So you insert the needle here. This will be called as posterior approach. So again I repeat, the anterior approach is on the lateral side of thyroid cartilage, right, along the medial border here. The posterior approach is from the take the point from clavicle to mastoid process and take the 1/3 of this line. You got my point? At 1/3 you insert the needle here. The needle direction should be towards the sternal notch, 45 degrees. This is called posterior approach. Then the second approach is what is called as central approach. So central approach is what you are going to show us. So show us the central approach.
Central approach is when you find the 2 heads of the sternocleidomastoid.
Yes.
Then you identify the apex.
Yes.
And you
so
mark
while
the
two ends of this sternocleidomastoid meet will form the apex. Yes.
To which we insert the
So it is here
needle.
That we have to insert the needle.
Yeah,
yes.
at the apex.
Okay. Okay. So we have localized the area. For the central approach, we take the apex of this triangle formed by sternal end and clavicular end of sternocleidomastoid muscle. The base will be formed by clavicle. The apex is the union between the 2 muscles. So here you will insert the needle. So which is the first needle you will insert?
The finest,
the thinnest needle, right? The 25 gauge needle. And you will give the, yes, these are the needles here. Yeah, before that you clean, so you have to clean the area. Now you came to know where is the area which is to be cleaned. Yes. So you will soak it with the chlorhexidine, then you start cleaning it from inwards to outwards. And large area is to be cleaned. So you clean the large area. Yes. So large area to be cleaned. You can clean it 1 time, 2 times, or 3 times. 1 or 2 minutes, right? Till you are satisfied that everything is cleaned properly. Okay. After cleaning, you will drap the area. Okay. So area is draped. Yes. Area is draped. Then once area is draped, we take the xylocaine 1%. Now you see, now I will tell you here how deep is the jugular vein. The breadth of jugular vein, the diameter of jugular vein is 2.5 centimeters. And how deep is it? It is very superficial. Just let me tell first. It is superficial. It is only within 2 centimeters you should be able to find the jugular vein. Its distance is from 0.5 to 2.5 centimeters. In this distance you should find the vein. That means if you are introducing too deep needle, is that then correct? That is not correct. That is going to injure the tissues and vessels and all that. You must already, this knowledge should be in your mind that the jugular vein is superficial. It is lateral to carotid artery, and it is only 0.5 to 2.5 centimeters deep. You got my point? This should be in your mind. So before you do the local anesthesia, so you will do the, in this area you will do the local anesthesia 1%. Okay, all 4 quadrants. Okay, done. Okay, done. Done. Okay. So after that, which needle you will take? 22 gauge needle, which is called finder needle. You understand my point? So usually what the books will show, the other needle, the videos will show other. No, you have to use finder needle. So this is also a thinnest needle, 22 gauge. So we will try to find the. So you have to go very superficial. You should be ipsilateral. Why the direction has to be ipsilateral? Yes. You can try. Yes. So it has come now. You see, before wait here. Before introducing the needle, you have to first palpate the carotid artery like this. When you are finding the carotid artery, then lateral to the carotid artery, you will insert the needle. So needle is to be inserted at 45 degrees. You understand me? And it is to be inserted not too deep, only superficial. Up to 2 centimeters you can did it. One more thing is that you can introduce this. So you keep the needle there. You keep the needle. Now this needle will act as a guide. So we know that this needle is in the internal jugular vein. So you take the another needle, what is called as introducer needle, isn't it? So introducer needle is 2.5 inches, isn't it? Long, and it is 18 gauge. You don't remove anything. Now you see there are two methods. One is that you take this needle and go along this needle like this. Like this, you go along this needle down. You go along this needle. You understand my point?
Yes.
Because I know when it is touching the needle, then it will go internal jugular vein. You don't have to. So this needle can be inserted parallel to the finder needle. Then it's easy, isn't it? You will not mess this way, that way, and even if you for finding, it will have less injury. Or the another step is, if you don't want to do like this, then you can do like this also. You take this out, take the syringe out, everything out. Yes. So there is a nick here, isn't it? So through this nick only, keeping the knowledge in the mind that how I had introduced. So introduce the needle like this. So two methods are there. One is to insert this needle parallel to that needle, or you insert the needle after removing that needle. You insert this needle through the same hole. That is the importance of finder needle. That is why I am laying stress on finder needle. You understand my point? Now, if we do again, you just take the you just see. You see that it is in the vein. Okay, insert it towards the ipsilateral. Right? You can search it again. Yes, because I changed it, isn't it? For explaining, I had to change this. The ipsilateral is here. Okay, you can see now how to identify this is venous blood. The venous blood will be dark, while as arterial blood will be very bright, and arterial blood will come in gushes. It pulsatile, it will come in gushes. So the needle is in the internal jugular vein. After this, what is the next step you will do?
Take out the string.
Okay, but you put the finger, because you have to close the port, isn't it? Then you put the guide wire. So guide wire is to be first straightened. Okay. So I can show it. Let me show it again. So you take this is the J wire, right? This is the J wire. So you straighten it like this. After straightening it like this, you can introduce like this. Yes. Now move the guide wire. So guide wire is to be advanced how much? Now listen, the guide wire, as I said, that guide wire was having marking 10 and 20. So we have to advance up to 15 centimeter. But now I will explain. You see, if we go guide wire more than 15 centimeters, that means we are going towards the right atrium.
Yes.
That means we are going to damage the right atrium, which is not needed. Our aim is that catheter should remain in the internal jugular vein, just at the superior vena cava, where it makes the superior vena cava. Above that, you understand my point?
Yes.
So that means we should introduce the catheter between 12 to 14 centimeters. Is safe. 12 centimeter is very safe. If you try to go 14 centimeter, 15 centimeter, 16 centimeter, it is going to go deeper, deeper, deeper. We don't need to go so deep. We are only, our purpose is only that it should remain in the internal jugular vein, isn't it? It should remain at the end of superior vena cava. So the length up to that is around 12 centimeters. So that is why there is a range that between 12, some books write 12 to 14 centimeters. In this range, and it is also written that it is safer to keep it 12 centimeters. You got my point? Yes. But some of the books write 15 centimeters. I have told you what are the disadvantages going too far. So you have to be very careful. That is why after the catheterization we take the X-ray. After the catheterization we take the X-ray and we find out whether it has not, the catheter has not gone too far. Yes. So after, okay. So you remove, hold it, you have to keep it holding, because if you don't hold it, then it is going to slip. Yes, take it out. Yes. Okay. So after this, we remove what is called as this,
Needle.
the needle. The introducer needle is removed. Yes. And after the introducer, so after the guide wire, we give a nick. We take a 11 blade scalpel and we give a nick here. So we give by the side of like this nick. Okay. So nick is to be given. I can show it that we take the scalpel like this and we give a nick like this. You got my point? Like this. So once nick is given, then we introduce the dilator. How far you will go dilator? So dilator should also go around 1 centimeter. Don't go too deep because it is very big. You see how much big it is. If you puncture carotid artery, it will be hell. It will be fatal. Patient's life will be in danger. This is to be very much thought about the depth. You understand my point? So depth you can go, because we only want subcutaneous tissue to be dilated. So once it is dilated, you take the dilator, then you slide the catheter, Sildinger catheter or 2-lumen catheter. We got a multiple lumen catheter, 3-lumen catheter, 2-lumen catheter, 1-lumen catheter, isn't it?
Yes.
And you slide it over this thing. So from the other end, the guide wire has come, and you introduce this thing. Okay, straight into this. Okay, so it is going. You understand? It is going very freely. So we now you see this also has got markings. You can see here the markings are there. This is 1 centimeter, 2 centimeter, 3 centimeter. These are for each marking is apart 1 centimeter. You can see markings here. But first mark is 10 centimeters. If you take the tip, suppose if I take the tip here, right? The first mark will be 10 centimeters. So it is here first mark, isn't it? This one. So this and this length will be 10 centimeters. After the 10 centimeters, now this is 10 centimeters. Now 10, 11, 12, for example, 13, 14, for example, 15 centimeters. If I go like this, if I go this much of this thing, if I keep this thing, this may be 15 centimeters, this one. So this catheter was 16 centimeters length. This is 1 more centimeter here, isn't it? This catheter is 16 centimeters. But question is, are you going to go 16 centimeters? Because you know what will be the problem.
Yes.
Better is to go 12 centimeters. Or safer is to go 12 or 13 centimeters. Don't go more than that. So you keep it little bit and this thing, and then take this thing and cap the ports, right, so that the blood doesn't ooze out. Okay. So this is done. After that, you will do the you will
Flush.
okay. So after that you will flush, isn't it? So you take around 20 ml heparinized normal saline, isn't it? Heparinized normal saline you take, then for each port, and then flush it. Okay. Okay, done. Then put the knob, right? Take the other one. Be careful. Okay, so done again here. Yes, then put the knob. Yes. Now we will suture the catheter, and we will anchor the catheter with the skin, isn't it? So you can just it will be here, isn't it? For example, now you take the suture, needle is there. Okay, so we can suture it like this. Okay, okay, done. There, the hole is there, isn't it? See, where is the hole? Here is the hole. Okay, first you take it from there. So we are suturing it. You understand my point? We are anchoring the catheter with the skin. Okay, done? Yes. Okay. So, okay. So, okay. Okay, yeah, okay. For example, we have done it. We are just showing it that we are doing suturing. So leave it now. Okay. Right? Okay. So after the suture, we just tie it. Okay. After that, you can cut it. Okay. There's no scalpel is there. Okay. So cut it. Okay. Okay. Then we will put the dressings. You understand my point? So get the dressing. You cut it here. Cut this one also. Complete procedure we have shown, isn't it? Now you can put the dressings like this. Or okay. You got my point?
Yes.
Okay. Then this can be also covered by the gauze. You got my point? You can cover it by the gauze. This is how we do the central venous catheterization. You understand my point? This is how we do the central venous catheterization. I think we have completed all the steps. We have not left any step, right?
Yes.
So this was a now one more thing. Now suppose if we have to do this, we have to do under ultrasonography. You got my point? How to do that? Now let us. You take it out. Take it out. You can pause it now. Now I want to show you how to do the central venous catheterization under the ultrasonography. Now this is a ultrasound probe. You understand, or transducer. First of all, what this transducer will do? This transducer will do. It will pick up the image. When we put the transducer like this is called short axis. If we put at the area we know area was the apex, isn't it? When the two sternal ends, whether the two ends of sternocleidomastoid muscle meet, that is the apex. So we keep it here, for example, right? And the image will be displayed on the screen. This is called short axis. In short axis, we get both the artery and vein will be shown on the screen. The vein will appear bigger and superficial. The artery will appear circular in case of short axis. You got my point? And if I try to press it like this, suppose I try to press it like this, then vein will get compressed. It will get compressed. or it will get collapsed. The artery will not get collapsed. And artery will show pulsations. It will be pulsatile. The vein will not be pulsatile. So we'll be knowing which is vein and which is artery. So in this short axis, we can then introduce another axis is the long axis. So we can hold like this also, introduce this transducer, and we can find the image. The image will be displaced, and we can make out which is vein, and vein will be more larger, isn't it? And it will be around 0.5 centimeter to 2 centimeters depth, and or anything is to be deleted.
But we nearly finished anyway.
Okay, I can continue?
I think we nearly
Then-
finished.
Yeah.
We can continue.
Okay. Okay. Now this is the short axis. You got my point. Now you introduce the needle. So introduce the needle, right? So on the screen you will be seeing that where the needle is going. It is to be ipsilateral like this, isn't it? It goes towards the ipsilateral nipple. So when you introduce the needle, it will show that it is going into the vein by using the ultrasound probe. And this is 100% success. You got my point? That is why we choose this vein, the jugular vein, as central venous catheterization. So this was all about how to do the central venous catheterization by ultrasonography, right? So I should be very thankful to you, right? You have already made one video on the lumbar puncture nut, right? And this is the second video on the internal jugular venous catheterization. So it was very nice to have you. You are so cooperative, right? I must thank you, and it will remain as a memory with us, and we will pass it on to others. Thank you so much. Thanks a lot. Thank you. And thanks for the cameraman, right?